Okay, give everyone a couple minutes. I guess we'll just get started. Um, Hello, everyone. Thank you for being here. My name is Taylor, and I'm the Assistant Director of Clinical for ProHealth One. And today we'll obviously be discussing wound care and legal compliance and understanding your risks and regulations and everything that kind of comes along with that. Like I always say, it's not fun unless we talk about something legal. So glad you guys are here. If you do guys have any questions, feel free to add it into the chat at any time, and we'll kind of go over any of those questions at the end. And as a reminder, you may earn CEs for this webinar if you stay on and answer all three poll questions that we have, and then certifications will be sent off once completed and reviewed. So just some housekeeping things. I have no disclosures or disclaimers, just that this is meant for education purposes only, and reliance on any of this information is solely at your own risk. So our objectives today is to understand the basics of potentially faced legal proceedings, and then just kind of going over some basic legal terminology as we go through it, understanding the legal implications involved in the nursing role for your wound care patients, key components of appropriate and required assessments, will identify the high-risk areas for nursing and wound care, and then also learn the potential impact and legal risks related to wound care specifically. So my biggest goal truly is to help you protect yourself in your own practice while delivering the best evidence-based, high-quality care to our patients. So I'm actually going to start off with a poll question. So how confident do you guys feel in your understanding of wound care regulations in your facility settings? So we'll give you guys some time to answer that question. All right, so we have some people said somewhat confident and not very confident. So I'm glad you guys are here because we're going to go through it all. Ooh, maybe. There we go. So why all of this is important, we'll kind of discuss it in for our own practice. So we have an ethical and legal obligation, it's a new term I just created, to provide optimum care to our patients. And we also want to have personal pride in our own practice. It's why we became healthcare professionals to take care of people. But when we provide substandard wound care, we can not only harm our patients, but as a result of that harm, the family member or resident, whoever it might be, can take legal action against you and clinicians involved in that patient's care. So all of your team members as well. So kind of if it happens to one, you'll get dragged into it. So the best we can care for ourselves and those on our team. So I will take you back to nursing school for a second. Just a reminder, we do have the Board of Nursing, and it's really important to know your state's Nurse Practice Act to ensure patients are receiving that high quality care and remain safe. This also ensures that you follow your scope of practice for your specific license. I did add the link to the bottom in case you needed a refresher, but as always, it is our duty, first and foremost, to do no harm to our patients. So just wanted to put it all into perspective. A report came out in 2024 that marked the 3 highest areas for claims in the long-term care and SNF setting in the United States. So the first and the highest one was falls. So about 1,840 claims that came out had a total payout of about $448.8 million for all of those claims, which is pretty high. And the second, which is why we're here, is the wounds or skin injuries, which is the second highest. So there were 773 claims with a total of $220 million for those claims. Last but not least is infection. So that's the third highest for claims. There was 461, and that totaled out for about $153.1 million. So it's expensive. So let's try to get us to not have these claims come at us. It's not fun. So I just want to review some definitions because we'll talk about this through the presentation, and I know legal has its own language, so I just wanted to talk about the three main ones so you guys kind of know what I'm talking about. But litigation is a legal process for where parties resolve their disputes by filing a lawsuit and then presenting that case in court for that binding decision, whatever it might be. So malpractice is where a professional fails to perform their duties properly and then cause harm as a result. And then negligence is failing to do what a reasonably and prudent person would do in that exact same scenario. So we'll talk about those and kind of what they mean as we go through. But some other key terms that you'll see that attorneys love to use when they're trying to build their own case are failure to, ineffective, incomplete, improper, lack of. Those are the terms that they love to use when they're building out their case. So we're going to review these again throughout the presentation. And my first example is failure to follow standards of care. So whether that's performing an admission assessment, failing to adhere to policy and procedures, or failure to follow a physician orders. And again, this is just related to wound care. So when we don't, or we fail to perform an admission assessment, we are failing to find that baseline for that patient. So then we, in turn, fail to implement interventions, and then we also fail to start treatment as quickly as possible. And if we fail to adhere to policies and procedures, there's not much your company can kind of do if they have them lined out for you. So it's really, really important to know what's expected from you from your company. And last but not least is to follow a physician orders. We're going to talk about this a little more in depth a little bit later, but it is very, very important to be following those physician orders, even if we don't always fully agree with them. Another failure too is failure to use equipment in a responsible manner. So if we are failing to follow manufacturer recommendations or we fail to even learn how the equipment functions properly, we could have a malpractice claim that comes from that. If we fail to check the equipment for safety to make sure it's working properly before we put someone, like example here, into a Hoyer, and something happens, we could be in trouble for that. And then placing equipment properly during treatment as well, just to making sure again that we're using all of our equipment properly. So it is really, really important to do those annual trainings or random checks to ensure equipment is functioning the way that it's supposed to, and then that staff are also using it correctly. Moving on to failure to communicate. This one's really, really big. So if we fail to notify a physician or someone with a higher medical authority when the condition warrants it, we could be liable for whatever kind of happens. Biggest thing is to listen to complaints from our patients and act on them. So even if we have someone that's a kind of a chronic complainer of something, we should be always taking that seriously because they might actually be, something might happen from that, whether it's a pressure injury that shows up a little bit later just because we kind of ignored that they had a little pain in their hip because they always complain of that. So it's really important to take them very seriously. And it's also important to notify family members, especially if they're their POAs, so that they can kind of know what's going on with those people and or with our residents and the wounds and kind of the status of everything. And then we have failure to document. This one is probably the biggest, and we'll talk about this quite a lot as I kind of go through this presentation. But we failure to document either their progress or response to the treatment for that injury. So either way, if it's getting better, if it's getting worse, if it's remained stable, if it's stagnant, we need to kind of know what's going on with that treatment and how well it's working or not working. Another thing is physician medical orders, making sure if we get new orders that we're documenting them and putting them in the chart quickly, so that way we're doing the right thing. Documenting any telephone conversations with physicians or anyone you have a conversation with is important. So using our SFAR, again, taking you back to nursing school to notify the time, content, actions taken, everything that's going on. It's the beautiful, if you didn't chart it, it didn't happen. It's very real in the legal world. If you can't prove it, it didn't happen. Another big part of it is refusals and noncompliance. With this, and I talk about it a lot when I do in-services for facilities, but you have to report and document the refusal and noncompliance every single time. So doing a giant note at the end of a shift saying, hey, they refused everything this shift isn't really accurate anymore. They kind of want you to chart every time that you talk to them, you did education, who did you let know? Did you try again later? Whatever you did needs to be in that documentation for refusals and noncompliance. And same thing for, everyone that's on your team, whether it's CNA, nursing, PT, it should all kind of align if they are refusing everything. Another one is failure to assess and monitor. So failure to doing a shift assessment or providing or effective interventions and making sure that they are working. And if they aren't working, did you implement a plan of correction? Observing that patient's ongoing process or progress as they heal again or they start to deteriorate. And super important for vital signs in labs and radiology. So if you pulled labs, make sure they're reviewed and sent to the right people to interpret them for you. And last but not least in this portion is failure to act as a patient advocate. So question everything. If it doesn't make sense to you, use your nursing or healthcare gut. It doesn't really lead you wrong. So question discharge orders if they don't make sense, if they're incomplete, if you can't read it, if they're doing their scribbles. Super important to question everything so we know we have the right orders going on. And it's also really important to provide a safe environment because if we don't, again, we can be held liable for that. So kind of how we protect ourselves through all of those failure twos is collaboration. So getting that collaborative team approach between primary care, wound care, nurses, CNAs, the therapy teams, your registered dietitians, management, making sure they know what's going on so then it can all be pulled into a risk management team and evaluation. So that way we can get all the right interventions in place. But collaboration is a very key component to all of this. So I do have a real life example to show that this actually does all happen. But a dressing was found by a nurse that had not been changed for 3 days, even though the order was for daily dressing changes. The previous nurse responsible had signed off that the order was completed. So the nurse that did not do the dressing change, even though she said that she did, was then terminated from her position. That termination was reported to the Board of Nursing, and then a hearing was requested. That subcommittee found that RN violated sections of the Nurse Practice Act that govern negligence or failure to, so those key terms we talked about, due care, incompetence, and lack of good moral character. So that all resulted in a 1 to 2 year probation and about a $250 fine. And I would have to assume she probably, or he, had a really hard time landing a job after this, and especially after it was sent to the board. So some key takeaways for this is that truthfulness is always the best approach and it should be your guiding mandate, whether you're talking to your employer, if you're in an administrative hearing or in court, no matter what, it's best to be very truthful about what happened. Because automatically when we kind of lie or document about stuff that we didn't do, but said that we did do, our moral character becomes an issue and then your credibility is kind of shot. So kind of having that pride for our own practice kind of goes away when we aren't being truthful about what we did. So now I'm going to kind of switch over to malpractice claims and what it all means for what malpractice claims actually mean. So for a malpractice claim to kind of come to fruition, all of these 4 things have to be proven for it to happen. So you'd have duty, breach of duty, cause, and damages. So what that means in terms of negligence law is that duty is referring to the patient's legal responsibility to act with reasonable care towards other people. And breach of duty happens when they fail to meet that standard that they were supposed to be responsible for. And then cause is going to connect that breach of harm or breach to the harm that occurred. And then damages are the actual injuries or losses suffered as a result. But again, for all of this to prevail, you have to have proof of all of these beyond reasonable doubt. So kind of what that looks like, and I have a bunch of examples this as well, is high risk area is treatment and care. So over under the patient did not receive the appropriate treatment of care. An example of this is a wound care treatment order is truly considered a legal physician order. So it's the exact same thing under the law as a medication order. So they aren't less than each other. They are very equal to each other. So when we fail to complete dressing changes, it is considered a mismedication and can also be considered negligence. And why it can be considered a mismedication is because many wound orders have a medication as a part of that dressing order, whether it's Dakins, honey, silver gel, whatever it is, that is considered a medication. So, according to a 2016 National Healthcare Safety Report, 1 in 9 malpractice cases between the years of 2010 and 2014 involved a medication issue, which is a lot. That's a high percentage for just medication administration failure. So another high risk area for a malpractice claim is, again, communication failure. So whether that's staff to patient, staff to resident, staff to family, staff to staff, there was a breakdown of communication somewhere, which caused harm to a patient at some point. So more than 7,100 malpractice cases involved a communication issue between the years of 2009 and 2013. So communication is very, very, very important. Two other high-risk areas for malpractice claim is informed consent. So either it was never even obtained or it wasn't even charted that you did get the informed consent to whatever procedure you were going to do. And the last one is documentation. So that's errors and omission. An example of that is if you do have a missing wound bed quality or missing measurements in your documentation, that is considered an error under the law and what the kind of attorneys are looking for. So putting all of this into play, my goal again is to help decrease chances of litigation. So now that you kind of know the ways that you can be involved in a malpractice claim, we'll decrease those risks hopefully. So we will be talking about proper wound care documentation. So the medical record is arguably the single most important piece of evidence in a malpractice case. So this is what attorneys are looking for. They're going to look at this from top to bottom every single way. So they want to determine if the standards of care truly have been met. And this is really going to determine if the defendant or the plaintiff wins, or aka if the patient wins or if you win. It's all based on your documentation. So I do have another poll question for you. So how often do you feel documentation practices in your facility protect you legally in wound care situations? So this could either be your own documentation or if you're in management, kind of what's going on in your facility. I'll give you guys a second to answer those. All right, so we kind of have everything. So some think documentation is consistent and thorough, which is awesome most of the time, and sometimes, which is all great. I'm glad I don't see any regular or rarely, but it's awesome. So we will talk about a little bit more on documentation and medical record reviews, and kind of we can help you guys with some missing parts if there are any. So again, your medical record review. So a competent attorney will just create havoc if there's any gaps that exist in that medical record or if they're finding any incomplete charting. So what that kind of looks like for wounds is, especially if the claim is involving ongoing treatment, which is wounds. So whether that's, they've been in treatment for a couple weeks or that wound's been around for months or even years, that is an ongoing treatment that they're going to be looking at. So lack of documentation on outcomes, observations, and treatment strongly will indicate negligence. So if we're missing any part of it, they can hit you for negligence. So an example of this is a pressure ulcer, which, just like all wounds, do require evolving treatment plans. So they have to be supported by thorough ongoing evaluation. So kind of what's going on in the wound bed needs to match the treatment, and the treatment needs to match with what the wound needs. And it needs to keep changing as that wound is evolving and healing. And again, I talked about it, but this isn't the most important, especially at the start. We need to have a baseline. If there's no baseline, then again, attorneys are going to attack that because they want to know where this started to come from. So, wound care documentation essentials. So, these are all the things we need to be looking at with documentation. So, head to toe skin assessment. Again, this is for your new admissions, but is it a new wound? Was it present on admission, especially if they've come back from the hospital, whatever it might be? Need to figure out where it was obtained at. Also, is this wound avoidable? Is it unavoidable? Which we're going to talk about in a little bit on how to decipher that. Description and quality of the wound bed, consistent measurements, etiology, and it really does need to be physician confirmed. So it's really best not to guess what it is and just call it one thing when it's really another thing, and then that documentation doesn't really match with each other. Attorneys are going to be really curious on what's going on with that. Pain with that wound, which again we're going to talk about in a little bit. Any preventative measures, nutrition, hydration status, so making sure your registered dietitian is involved in their care, especially if they have significant wounds. Current treatment or any order changes after assessment. So again, ever evolving treatment plans, making sure that they are the most up to date and current. Making sure you understand their risk factors and comorbid conditions, because that's really going to drive the interventions for that patient. Any physician or family notification, and again, any education that you provide. And even if you're giving it, 4 times a day, making sure it's being documented every single time and their response to that education. So in documentation, it's really important to remember what we should be looking at. It's really important to avoid absolute words in any written guidelines or standard operating procedures or documentation that you're doing. So you kind of want to avoid using the words always, never, must, shall, immediately. Those are just absolute words that we really shouldn't have in our documentation. Another thing, again, is becoming aware of your facility standards of care, because the chart, which is your charting, is actually going to be compared with the facility's written regulations, their policies and procedures and guidelines at the time the care was rendered. So even if something happened in, let's say, 2018, and now a claim is coming out and they're pulling you back from something that happened in 2018, they're going to match the policies and procedures from 2018 to that date. They're not going to be looking to see what's happening in 2025 with those procedures and matching it to whatever happened in 2018. So it's really important to know at all times and every year if there's any updates, your facility's policies and procedures, just to help save you. But a few more proper wound documentation tips, the 3 C's of ideal charting to make sure it's clear, concise, chronological, so it makes sense and there isn't a lot of backfill or late entries, making sure that's all in there. It's continuing and it's reasonably complete. So we always recommend setting yourself up for success. So document if you're looking at your own documentation through a legal lens. So just taking another little second to think, how could I potentially get in trouble for this documentation? And also, again, kind of looking back, if something comes to you or a case from 2018, you want to make sure your charting makes a lot of sense and you know exactly what's going on. Because I guarantee you're not going to remember what happened on April 12th at 12 o'clock in 2018. But if you have really great documentation, you're going to be able to pull that and be like, oh yeah, this is exactly what happened. And you're taking out the entire guessing game for that. So big thing I do want to talk about for wound care, since that's what we're talking about, is the top wound care lawsuit, which I don't think I'm going to surprise anybody, but it is pressure injuries. So in 2009, pressure injuries were present in in 7.5% of long-term care patients, and that total cost for those pressure injuries was more than $3.3 billion, which is crazy if you really break it down and think about it. And in those cases, 87% of plaintiffs, so the patients, were favored in those cases. So patients are going to win a lot at a higher rate than we will as the defendant. But 17,000 pressure injury lawsuits are filed every single year. With a malpractice lawsuit, the average settlement is $250,000 per lawsuit. So could be a little less, could be a little more. So, but $250,000 is a lot of money. So why it's super important for us to know the risk factors of all of our patients. So we need to know what's going on outside of the body and what's going on inside of the body. So those extrinsic and intrinsic risk factors. So we're looking at every single patient. They're all going to be a little different. But our extrinsic factors, so we're going to look at, pressure from prolonged immobility. Is there any friction or shearing? Is there any moisture from incontinence, sweat, increased wound drainage? Do they have a medical device? So they have a catheter or oxygen tubing. Those are all the things we kind of need to look at what might cause a wound outside of the body. But we also need to look at and compare to what's happening on the inside of the body. So our clientele, they're a little bit older. So as we age, we obviously have slower cell regeneration. So wounds are going to heal a little slower than if we were 24. We need to look at poor nutrition and any vitamin deficiencies, chronic diseases, obesity, smoking, because it's going to reduce the oxygen delivery and dehydration. So again, we're going to look at both and kind of compare, and then hopefully get those wounds to heal. But another thing to be aware of is determining if the wound is an acute wound or a chronic wound. So an acute wound is going to heal in a very predictable and timely manner. It's usually going to heal within a few weeks. There's no surprise, so it's going to heal the way that we anticipate wounds to heal. Our chronic wounds, they fail to progress through the normal healing stages. And so these are going to persist for months or longer. And CMS actually describes a chronic wound if they heal in greater than 30, or if it takes 30 days or more for them to complete wound healing, it will automatically be a chronic wound. So when kind of looking at this is going to help us determine if it truly is an avoidable or unavoidable pressure injury. So when it's an acute wound, it's probably not going to be unavoidable unless it turns into a chronic one. But looking at avoidable and unavoidable, CMS kind of helps us out and kind of breaks down all the steps that need to be completed in order to call it an unavoidable pressure injury. So the first thing we need to do is evaluate the resident's clinical condition and their pressure ulcer risk. So really important to do the Braden scales and just making sure we have everything in place and know what their baseline is. And then did we define and implement any interventions that that person might need? And they need to be consistent with the resident's needs and goals, as well as standards of practice. So say we put in interventions, do we monitor and evaluate those interventions? So are they working or are they not working? And if they're not working, did we revise those approaches as appropriate and try new stuff? So you're probably going to go through this a few times before you're going to call it an unavoidable wound. But say we meet all that stuff, CMS also does help by acknowledging that not all risk factors are going to be fully modifiable or can be addressed, or it's going to take time to correct any of those risk factors that we might have despite proper interventions. So an example is, malnutrition or uncontrolled blood sugars. Those are not, even if we start getting them under control or fixed, that's not going to be changing within 24 hours. It's going to take time to level out those blood sugars, to increase that nutrition, and then that's going to reflect that wound to start to heal. So they do thankfully at least acknowledge the fact that even though we're doing everything, these wounds might still just be unavoidable. So some other examples of when we can kind of use unavoidable is our end of life wounds. So we have two. I'm sure you guys have all heard of them, but we have scale wounds and then we have Kennedy terminal ulcers. Our scale wounds, so skin changes at life end is what it stands for. But those skin injuries are breakdown that occurs a natural part of the dying process, and they're going to be unavoidable despite appropriate care. Just like a Kennedy terminal ulcer, it's mostly related to multi-organ failure, poor perfusion. That blood flow is going other places and not in the skin to get that wound to heal. They're just getting to the heart to keep it pumping. But your KTUs are different than scale wounds, but they do resemble pressure injuries pretty closely. And usually your Kennedy terminal ulcers cannot be diagnosed until after someone has already passed, just because of how quickly there's a rapid onset, rapid deterioration. They take on an appearance of a butterfly or pear-shaped, and again, very much resemble a pressure injury. And I do have an example of a Kennedy terminal ulcer to kind of show you the progression and how quickly it can happen. So the lady that, or person, can't remember if it was a man or girl, but the person I'm going to show you, this was from week 1 to week 2. And prior to week 1, it was all the skin was intact. It just was starting to break down a little bit, but it didn't look anything like this in the previous week from that to week 1. So our week 1, you can kind of see it starting to take a little bit of a pear butterfly shape. It's already getting necrotic on the edges, that wasn't present then. And then literally they had every single intervention in place. Treatment made sense. They were offloading all the time. And from week 1 to week 2, it turned into this. And then we come back and we try to clean it up a little bit, make sure it didn't get an infection. And then week 3 to week 4, it progressively deteriorated despite all interventions. So by week 4, it's necrotic. We can't really debride at this point. They did go on hospice and passed away. I think that same week of week 4. So just kind of showing you from week 1 to 4 weeks later, despite every intervention, that wound deteriorated really, really quickly. So after that, then we were able to determine that it was a Kennedy terminal ulcer and have proper documentation to reflect that. So an unavoidable note example is also going to be really, that I have for you, is important. So the more documentation you can have in your unavoidable note, it's going to make it a little bit more, I don't know, it's gonna be nicer. So if you just put wounds are unavoidable and that's all you say, it doesn't really show any substance to what's going on with that patient. So I did randomly write one. So a patient has chronic non-healing pressure wounds that have been treated with multiple therapy types. They have a past medical history of paraplegia, depression, contractures, neuromuscular dysfunction of the bladder. They have a colostomy. They have a BIMS of 7, and they have frequent refusals of care. Staff have all interventions in place, including but not limited to, and then you list them out. So pressure relieving devices, they're in a turning and repositioning schedule, offloading, we're floating the heels, we have supplements, RD's following up on the intake of those supplements, education to patient and the POA. And we brought in the POA because of a BIMS of 7, so poor decision making. They have a colostomy and a catheter in place. PT and OT have seen as indicated. So despite all attempted therapies and interventions, wounds show no promise of wound healing and wounds are deemed to be unavoidable. So this paints a picture of that patient and everything you've tried, refusals, who you brought in, who's in constant evaluation. You're looking at those extrinsic and intrinsic factors and really just creating a story to show that it is unavoidable. So the more you can put in there to paint that picture, the better case you have. So kind of moving forward, that kind of goes with wounds, is pain and suffering. You're going to see this a lot more. They're kind of coming after this a little bit more, especially for our elderly. So there is a new wrinkle of concern for our elderly. So when attorneys are going to sue someone for something, and they are an elder, they're actually kind of skipping the malpractice claim that they're going to give, and they're going right for elder abuse because there's monetary limitations on a malpractice claim, but there's absolutely no cap when it comes to elder abuse, so they can sue for a lot more money. So now they're trying to go for elder abuse and kind of skipping the malpractice claims. So what that kind of means for us is we do have a growing elderly population. So pressure injuries are more likely to develop in those that are 65 or older. And in the next 25 years, it's predicted that this age group is expected to double, therefore dramatically increasing the number of patients with these types of wounds. And it's also estimated by 2030, almost 1 out of every 5 Americans are going to be 65 or older. That's about 72 million people. So gives us job security, but that also gives us a lot more to be paying attention to for our patients we're taking care of. So pain and suffering allegation to do. So this is going to help everyone when we're looking at pain specifically for wounds. Recording location with every single pain assessment is going to be important because if we don't put, that it's from a chronic condition and not from the pressure injury that they might have on their heel, an attorney's going to automatically assume that pain is going to be related to that pressure injury, and we can't really prove it because we didn't document that location. So it's going to be really important to document location, routine pain levels, and any reassessment. So it's really important when you find a new wound to automatically just do a pain assessment just to make sure that pain is covered. Reporting those high pain levels to the providers so that they can adjust and do whatever they need to do. Prior to dressing changes, you can always pre-medicate, whether that's oral or topical, whatever it might be, but that is always an option. And then implement proper interventions and follow through. So kind of whatever's causing them pain by, if we're offloading and that's helping, then we can keep those interventions going. So if we do have improper assessments, interventions, or follow-up, it can lead to additional allegations. So it's really important to document thoroughly for pain. And there's truly not enough patient education documented on the subject of pain management. So it's, again, just really important every single time you're assessing or asking about pain to document and kind of what you did for it. So how to avoid those allegations. Again, take you back to nursing school. We're going to do old CART. So we're going to look at onset, location, duration, characteristics, aggravating factors, radiation, treatment. We're looking at all of those things. Making sure that we are using the proper pain tool based on their orientation. So either the 1 to 10 scale or that unresponsive or flex scale to kind of help determine their pain. But things we can do on the wound care side is silicone back dressings are a little bit more, they're nicer to the skin. They're not as painful to remove. Decreasing frequency of dressing changes. So changing it from every single day to every 3 days or whatever it might be, just might be enough to decrease that pain for them. Administering around the clock pain medication if needed and making sure that's on time. Planning that dressing change after that scheduled pain medication is given, so that way it's not as painful for them. Again, using topical or systemic use for pain medication, see what works best for each patient. But for wounds, it's also super, super important to evaluate the possible source of that pain, whether it's an infection or they don't handle debridement super well, whether it's trauma to the wound or whatever it might be. There might be more reason that they're complaining of pain and we need to take it seriously and evaluate and see what's going on and see if maybe it is an infection that we need to get ahead of. So my final question for you all is what is your current level of awareness regarding your legal responsibilities in wound prevention and care? So I'll give you guys a few seconds to answer that one. Beautiful. So everyone either has a high, moderate, or low understanding, which again, it's why we're here and we'll offer some other additional things. So I'm glad you guys are all here. But kind of jumping in, so kind of reviewing everything, how can we as ProHealth help you and your patients at this point? So we do provide education and audits, so we can kind of help put your mind at ease with some stuff. We do have a legal nurse, which is myself, on staff that can help with reviews and kind of look at it with a more legal lens with you guys. But we also have 2 incredible other nurses that are so smart, so talented, that have a really good opinion. So we have a full nursing team that can help with all of these reviews. So we can do wound care chart reviews. We do have auditing, mock surveys for wound care. We can do state interview preparation, especially for those questions that state's going to ask and you're not really sure how to answer them. We can kind of help guide you with that. And we do have staff education. So kind of when I went over now, we have a full legal presentation as well for staff and kind of can break it down what that means for them to kind of help increase that knowledge. So we have a lot of services we can offer you guys. But just here's my email. If you have any questions, please feel free to email at any time or our general information. As always, we do have an outpatient clinic so we can help with advanced treatments. So total contact cast, vapor-ox therapy, we have Moleculite, we have ostomy care and education and kind of everything that you need for that advanced treatment or if they've been discharged. So last thing I'll talk about is we do have some upcoming webinars. We are going to take a break for July because hopefully everyone gets a nice little vacation for July. So we're going to take a break, but we will be kicking up again in August. And we're going to be reviewing significance of chronic wound management at that webinar. So that's all I have. Is there any questions? I can't see anything. If there are.
I don't see any questions as of now. If anybody has any questions, feel free to click that raise hand button. No questions, Taylor. Thanks so much.
All right, well, thank you all for your time. I appreciate it. And please feel free to reach out for any other questions that you might think of or come up with, but appreciate all being here.